Board Bombs.
And we're back, EM Board Bombs. Welcome back to another lovely episode. Dr. Wasiski-Kuhn is with us again. Thank you so much for being here.
It's great.
The AC is not working where you're at right now, so this is... Yeah.
Forgive my beads of sweat.
Yes. If you hear drops in the microphone, it is indeed not water. Well, it is sort of, but it's not the water you Anyway, this is EM Board Bombs. Obviously, we joke around a lot. This is not your average serious EM podcast. We're the blue-collar podcast of emergency medicine. Hashtag Iltifat Hussein. He coined that. He'll get credit for it. He's not here, though, as you can imagine. Whenever it's Marlene and I, Dr. Hussein is doing something else. Doing something else. He's probably on a plane. That's 90% of the time what the jokes go to. He's on a plane somewhere, or he's doing something with coffee somewhere.
On a plane to a coffee plantation.
Yes, one of the two. Something very related. I shouldn't talk. He's gotten me to be a complete coffee snob too, so I blame it on him. It's contagious. Remember, EM Board Bombs were each 15, 20-minute episode you gain rapid, high-yield, board, and life knowledge. Speaking of boards, this is like the most, origin story EM Board Bombs podcast ever.
It is, really.
We're going to be doing an oral boards case again. We had such great feedback several weeks ago about an oral boards case Iltifat and I did, and I was the guinea pig. And so we've decided to do that again. Marlene and I were just talking before the podcast. People are going to start asking questions. They're going to wonder, did Dr. Briggs actually pass his boards? You know, I could be running EM Board Bombs with you and Dr. Hussein now for several years, and the running joke is I haven't passed my boards yet.
We're just secretly his private tutors because maybe one day.
Yeah. I remember when I first got a residency and I was about to take my boards, and I'd already been running EM Board Bombs. And I remember my chair said, so you got your boards next week, right? I'm like, yep. He's like, you feel ready? I'm like, yeah, I'm ready. He's like, well, it's pretty embarrassing if you don't pass your boards. I mean, you run a board company. And I was like, thank you for the vote of confidence. Yeah, don't jinx it, basically.
Nice.
He's like, how could you even keep doing that if you failed your boards? So anyway, obviously, dear listeners, I did not flunk my boards, so we're in good shape. So what we're going to do here is this structured interview, and I want to hear Marlena's perspective on this. I specifically remember something like this on my oral boards, and it's something that isn't really talked about. The cases are, but the structured interview is really awkward if you haven't had any experience before with it. And the best part is, those of you listening and you're tuning out, you're like, okay, this episode's going to suck. It's not going to be interesting. The fun part about this is, one, we'll make sure it's entertaining, and two, it's still a case. You're still learning something about like how to manage a certain type of patient with a complaint. And you know us, we're not going to do the company line here. We will tell you what is real life and what you're actually going to do for your patient in front of you. I want to give a shout out to who? Our only sponsor?
EM News.
Yes, Emergency Medicine News. The one and only. The news of emergency medicine. Said in the passive voice. They have a website. They deliver print copies to your house or place of residence. I just signed out one of my best friends, actually, the other day. He's like, I don't get EM News, but I'm an emergency doctor. I'm like, sounds like we need to change that. And I emailed the editor. Bam. He's getting print copies now. He's excited. He's old-fashioned. Awesome. He likes sitting by the fireplace and reading. So nothing wrong with that. Okay, cool. Why don't you introduce me here, as in lead me in? You've already introduced me. Why don't you lead me in into this structured interview here, and we'll get started.
Yeah, so in this case, I'm going to be the instructor. Yes. Dr. Briggs is taking his oral boards again, and we will keep it under the time limit, but I don't think you're going to need to actually keep track of the time because it's a pretty straightforward case. It's mostly about the thought process. So as we begin, hello, doctor. This is a structured interview case. There is no role playing. In response to the questions I will ask, please give me a list of information you would gather to come to a final diagnosis. At times, I may interrupt you to move through the case. This is not a reflection of your performance. You will have 15 minutes to complete the case. Before we begin, do you have any questions?
No, I'm totally ready.
All right. The patient we'll be discussing is a 27-year-old female with 1 hour of shortness of breath and wheezing. Here's your stimulus. So here's the initial information regarding the patient. After you have read it, please give me a list of the additional historical information that you would obtain. If you're watching on YouTube, you can see the stimulus reflected here on the screen.
If you're not on YouTube, I'll give you a summary. Essentially, it's a 27-year-old female coming in with EMS with shortness of breath. She is uncomfortable, tachypnic, but able to talk in full sentences. If this were a real oral boards case, the oral boards examiner will be wondering why I'm talking to myself. Notes on a notepad, needs psychiatric screening, but may not flunk the case. The patient didn't have her albuterol inhaler at work. EMS did not give any medications en route, and EMS states the vital signs were normal. Here are the vital signs. The patient arrives with a blood pressure 120/72. The pulse is 103. The respiratory rate is 28. Temperature is normal. That's 37 Celsius for those of you in Canada and 98.6 in America. And the oxygen saturation is 93%. Room air. Okay, I'm ready.
All right, go ahead. Ask me any other additional information that you would like to obtain of the patient.
Yes. When was the last time something like this happened to the patient?
The patient has not had this happen for a couple of years, but it is occasional.
What other medical problems does the patient have?
The patient has a history of asthma, and she is currently 20 weeks pregnant with her first child.
Oh boy. Oh, great.
Surprise.
How many weeks pregnant?
20.
Okay. All right, dear listeners, I didn't have that detail.
There you go.
20 weeks pregnant. Anything else that I should know
about? Nope. That's it for her past medical history.
Oh, great. And you said that she had been pregnant before?
She has never been pregnant before. This is her first child.
Okay. I don't know where I got that. And wonderful. So far, prenatal care has been expected?
She has not had any abnormal prenatal care. She had a confirmed IUP seen on a 12-week ultrasound.
Cool. Great. Any fever at home?
She is not having any infectious symptoms.
Okay. Clearly, they don't want me barking up that tree with that statement. Any vomiting at home?
She has not had any vomiting or any abdominal symptoms.
Also saving me from barking up that tree. Okay. And what has she done to treat her symptoms at home?
She was at work when this happened, and she did not have anything with her, so she just called 911.
Okay. Is she having any chest pain?
She's not having chest pain.
Okay. Got it. Has she ever required admission to the hospital for her asthma?
She has been in the hospital for asthma during childhood.
Cool. Has she ever required intubation or ICU for her asthma?
She has never needed the ICU or intubation.
Cool. Awesome. Any prior surgeries?
She has never had surgery.
Cool. Any allergies?
She does not have any allergies to medications.
Okay. And any drug use?
She does not have any drug use.
Any alcohol?
She does not drink any alcohol.
Got it. Cool. Any urinary symptoms?
The patient does not endorse any urinary symptoms.
Okay, I think I'm good.
Okay. During that, you asked about chest pain with the patient. Can you tell me why you asked that?
Chest pain and shortness of breath are often co-presenters and can suggest specific etiologies that are related. And so having an occurrence of chest pain could lead down a potential additional differential diagnoses.
Based on what you now know, please give me a list of specific physical exam findings that you would be looking for.
Cool. Well, I would go find my stethoscope in my bag. Just kidding. It'll be on me at all times.
Of course. How else will anyone know you're a doctor?
Yes. I would grab said stethoscope and I would first practice whispered plectoloquy, as they say. And then I'll do agophony. I'm just kidding. I would listen to the heart and lungs, specifically expiratory and inspiratory sounds. Because this is oral boards, I would listen extra long and extra more detailed to the lungs. I would also look at their work of breathing in all seriousness, look at how they're sitting up or laying down, or they're recumbent and complaining of shortness of breath, Are they texting on their phone saying they're short of breath? Are they actually short of breath? Using accessory muscles, lifting up their lower part of their shirt to look at, or gown, what they have on, to look at their abdomen and see if their abdominal wall has retractions. Also, I'd be looking for signs of volume overload. I'd look for JVD. In the semi-recumbent position, I'd look for pedal edema or hand edema too.
Okay. Doctor, you examined the abdominal wall for retractions during this. Please explain how that would help you.
Any sort of accessory muscle usage, so looking at the abdominal wall. This is particularly helpful in, depending on the body habitus, in kids and adults. You're looking at the muscles of essentially the chest wall, including the neck muscles like sternocleidomastoid in that area around the clavicles, as well as the musculature below the rib cage, looking for work of breathing.
Doctor, you also assessed for egophony during this test. I would like to know if that is part of your assessment of every patient presenting to the emergency department.
No comment. We can continue. Yeah, whispered pectoriliquy, which is a hard word to say. I'm embarrassing myself
Can't
that
say
word.
That at all. I wouldn't
Pectoriliquy. Oh my God. You have to really like squeeze your nostrils when you say that.
Pterodactyl.
Yeah.
No?
Iltifat would be slayed by that word. So apparently, so back in, pause, we can pause the oral boards for some light humor. Apparently back in whatever, a long time ago in the war, and back in the day, the British used to know if there was a German spy in their country, because apparently there's certain words that if you're German descent or German speaking, and hopefully our German listeners can verify this, they can't say. They just can't say at all. And so apparently squirrel is one of those words that the German people just can't like say it if you're a native German speaker. And so you can't fake that word. And so the idea was, if you were in England or something, you would say the word, oh, can you tell me the word squirrel? And I feel like pectoriliquy is a good, I said it pretty good there, is a good way to tell if you're ESL or not, if you're iltifat. He's like, iltifat, say pectoriliquy. And he'd be like,
that actually sounds exactly like it.
One of those two. So anyway, it's a little history for you right there.
Fascinating.
Yes, of course. I can't verify that it's true. I heard it on Top Gear one time. Anyway, continue.
Resuming the oral boards. Yes. You are provided with the following physical exam findings. Lungs are diminished at the bases with diffuse expiratory wheezing and slight tachypnea, as in the vital signs. There are normal heart sounds with no murmurs, no tripoding, and there are only some mild to moderate intercostal retractions. The Hient exam is normal. The abdominal exam is normal with the uterine fundus at the umbilicus. There is trace lower extremity edema, and if you had done a pelvic exam, that would be normal.
Interesting. Pelvic exams and asthma exacerbations.
So something to know about these cases, as a side note, is that they will provide you with things that you don't ask for. So you always get the summative information afterwards, regardless of whether or not you asked for it. And if you asked for something that they don't give you, that means that it wasn't important.
They'll also sometimes drop total like hints, like I was joking about earlier, that if you ask about a certain thing and they say, like if I asked about, oh, does the patient have any vomiting? And they'll say like, no vomiting. And also they have no belly complaints, aka don't ask about anything anymore.
Mm-hmm. Yeah.
So they just kind of drop those hints. So pay attention to that, what I was making a reference to earlier. Cool. Let's keep going.
Based on what you now know, what are the top 3 items on your differential diagnosis based on the most likely conditions?
Sure. So number 1 would be an acute asthma exacerbation. Number 2, we'll go with pneumonia. And number 3, we'll say pulmonary embolism.
Okay. So based on what you know and your working differential, what diagnostic studies would you order?
Sure. So for right now, given her previous history and her presentation here, our number 1 priority would be treating her asthma exacerbation, especially given her physical exam findings and her presentation and story. And then going from there, essentially using the treatment as our diagnostic approach. So right now I would order a treatment pathway for her asthma, which would include inhaled nebulizer therapy, oral or IV, whatever, steroids, and potentially magnesium, depending on her clinical status. IV magnesium.
Okay. Is there any other diagnostic studies you would order?
No, I feel the pressure. So for the differential, obviously we would be getting If we're worried about volume overload, we could consider getting a BNP. We can get an EKG as well since she's short of breath. There'd be some consideration of getting a troponin as well, too, and some laboratory studies for chemistries and a CBC as well, and metabolic panel.
Okay. Doctor, you mentioned getting an EKG for shortness of breath. How is that helpful in cases of shortness of breath in general?
So there can be nonspecific findings on the EKG, can suggest specific causes. Obviously, the most obvious one would be any type of ACS, so ischemic changes. PE can also show some ischemic changes, such as diffuse T-wave inversions. STEMI would be a minority presentation, not as common as T-wave inversions or nonspecific signs of ischemia. But you could also see certain arrhythmias that could be causing someone's shortness of breath too, especially tachydysrhythmias.
All right, doctor, here is your second stimulus with pertinent positives and negatives from the labs ordered. And you ordered albuterol nebulizers and IV or PO steroids. Why did you order those things for this patient?
Those are the primary, the primary cornerstone for treating an asthma exacerbation, as well as magnesium as needed for moderate to severe asthma presentations.
Okay. Based on everything you know about this case, what is your final diagnosis and disposition for the patient?
I would say this is an acute asthma exacerbation and requiring treatment in the ED, nebulizer therapy, steroid therapy, potentially magnesium therapy. And my treatment pathway would be following repeat nebulizer therapy, reassessment of the patient, and ultimately disposition would depend on her response to that therapy. All right, sweet. That was scary. I saw a new side of Marlena that I don't want to see again. It was very, very frightening. I'm literally intimidated right now. I'm very intimidated. Iltifat, I wish you were here right now. I'm literally just like sitting here with my hands in my lap, like, okay, yes, ma'am.
I'm seriously I'm gonna get roasted tomorrow by my interns as part of our graduation celebrations.
Oh, that's nice.
And we'll see what they say about how I was. Like,
here we are. I searched on Google, why can't Germans say the word squirrel? And it is a linguistics page on Reddit. Here's the first top comment. This guy seems very educated. It's pretty obvious why Germans struggle with the word squirrel. The soft W sound in English does not exist in German, and neither does the non-rhetoric R or the swallowed schwa I at the end. There are plenty of German words that English speakers struggle with too, but because so few of us bother to try to speak German, it seems like less of an issue. Oh my gosh, that's funny. If you want some fun, ask a person from Ontario to say theater. That's interesting. Think of that next time, people in the audience. If you're Canadian, you know where I'm coming from. Maybe, I don't know.
Drop us a YouTube video of some type of comment saying the word theater if you're from Ontario. Yeah. Thank you.
Here's another comment. I would imagine this word being especially maddening to German speakers, given that QU is often pronounced KV. Whoa, that's weird. Are there similar pronunciation difficulties with other RL pseudo-schwa sounds like girl and world? I don't know. This is getting deep into linguistics, which is so far away from what I'm good at. But it's like one of the last things. That and math.
Good enough to say petroliloquy.
So. Yeah, I can say some English words pretty well. And the Latin background helps. But anyway, okay. That is all we have today, ladies and gentlemen. Check out Rapid Bombs. I haven't mentioned that yet. That is just on our main website. You can go to emboardbombs.com, check out EM Rapid Bombs for really a fantastic way to rapidly prepare for your board exam. We give 2 to 4 minute episodes, tell you everything we need to know. We sometimes do certain series too. So this past week, I'm doing a long series on subarachnoid hemorrhage in terms of presentation, diagnosis, treatment, management. It's encompassing, but every episode is like 2 to 4 minutes long. It's fantastic. So check that out. And that's all. Marlena, you can say bye.
Oh, bye.
See you next time.